Good morning. Welcome to Infectious Disease and the Pre-Hospital Provider. During this presentation, I hope to educate you on how to protect yourself, your patients, and most importantly, your loved ones. We as healthcare providers traditionally do not protect ourselves adequately from infectious diseases. Many experts in the field feel that we should treat each patient encounter as if they have a potential infectious disease. Being an emergency physician, I have been exposed to more infectious diseases than I care to think about. And we as healthcare providers are notoriously bad for doing with the one single thing that we can do to prevent spread of antibiotic resistance, spread of disease and pathogens to ourselves and our other patients, and that is good hand hygiene. So, let's talk about bacterial resistance in the pre-hospital environment, and we'll go through some literature because I really don't like anecdotal stories. We all have them, we all thrive on them to make points. However, reaching out and looking at the medical literature really, I think, drives the point home. So, back in 1974, approximately 2% of staphylococcal bacteria were tested in the United States hospitals, and they were found to be drug resistant. This was done in 1992 study, so it's somewhat dated, but it stands to show us a good baseline. In 2008, Dr. Dave Talon, a wonderful person, in 2011, that's already 5 years ago, showed that this number increased to about 59%. This was done in an emergency department study where they looked at abscesses that were drained, and traditionally these abscesses could be drained, not put on antibiotics, and they would resolve. The incidence of MRSA had increased so much that it actually changed practice across the country. Multi-drug resistant bacteria are and continue to be a threat to pre-hospital providers because we as pre-hospital providers go out and interact with people and really don't know many times until after care has been transferred and they've been hospitalized what these patients do and don't have. This was demonstrated in 1997 by Shaylas. The predominant drug-resistant pathogen responsible for most purulent skin and soft tissue infections is methicillin-resistant Staphylococcal aureus, commonly known as MRSA. Again, this was a study by Dave Talon in 2011. The number of other agents, pathogens that are drug-resistant now include VRE or vancomycin-resistant enterococcus, and there are new and emerging strains of bacteria. To our most powerful antibiotics now, things like imipenem, which is really scary because this is kind of, to use a euphemism, a Godzillacillin, and if the bacteria become resistant to that, we are left with very limited choices. So here's another interesting study from Miramonte. Dave Miramonte was the EMS medical director for Washington, D.C. for a number of years. This was back in 2013. And they swabbed the nasal cavity of EMS providers from a hospital-based agency and EMT students. Not surprisingly, the overall rate of carriage, or how many people nasal passages carried MRSA, was approximately 5%, or 1 out of 20 providers. This was about 5 times the prevalence found among the public back in 2006. I can only imagine that this data is already 9 years old, and the carriage rates for healthcare providers has to continually go up. And simply by stepping into the hospital, you expose yourself to multiple drug-resistant organisms. So, are your ambulances clean? I would dare say no. 21 ambulances were tested in an urban ambulance fleet for the presence of MRSA. This is back in 2007. They sampled, swabbed various areas. The steering wheel, that's a common favorite. People who take care of patients don't change their gloves and then contaminate the steering wheel. The cot handrail, the cot cushion, the work area to the right of the patient, and the tip of the hard tonsillar suction. And I can only assume that these tonsillar suctions were clean and that they, quote, became contaminated just by the presence of being in the ambulance and infectious patients coming in. The scary part was that 50% of the swabbed ambulances tested positive for the presence of MRSA. And so this is more than likely due to the fact that the disinfectant agents need to stay on for a certain amount of time. They may not be appropriately used. There may be different levels of toxicity to the bacterial agents, and some are approved for certain viral agents and others are only approved for certain bacterial agents. So bottom line is your ambulance is not as clean as you may think. So another goodie, and this has been reproduced in multiple different healthcare environments, this one just was in the pre-hospital environment, is should you ever touch anyone with your stethoscope? Scarily enough, probably not. So they took 50 stethoscopes used by EMS providers in an urban service were tested for pathogens. This included things like MRSA. This is by Merlin in 2009. Researchers asked EMS personnel a questionnaire trying to identify the last time somebody disinfected their stethoscope. Well, not surprisingly, a third could not pinpoint the last time that they or someone else cleaned their stethoscopes. And so 16 of 50 stethoscopes, or about 1/3, tested positive for MRSA. Think about this next time you take your stethoscope and say, take a big deep breath. So you may have contaminated or infected or given this person MRSA inadvertently. And that kind of considered bad form. The hand washing literature. And public health is really very diligent about trying to get the message out. We as healthcare providers, both in the hospital and the pre-hospital arena, don't wash our hands as often or use proper hand washing technique. You think, what do you mean this proper technique? Well, you know, rinsing your hands off and calling it good just doesn't cut it. One of the most important interventions to reduce the rate of resistant organism colonization is increasing hand hygiene. In addition, we prevent transmission of these pathogens from patient to patient, patient to surfaces. Now, when you're in the field, obviously you don't have a spigot and you don't have access to completely wash your hands. So the commercial waterless hand cleansers are a temporary acceptable alternative. That said, after transfer of care is complete, you need to wash your hands as soon as possible. Wearing a gloves is not a substitute for proper hand hygiene. So, this training really is aimed at the individual pre-hospital provider. You know, as EMS providers, we're mandated to follow local EMS agency regulations, policy, protocol, your own private agency policies and procedures, and all applicable federal, state, and local laws and regulations. OSHA has a great deal to say about this for workmen's issues. In addition, Cal OSHA takes many of the OSHA standards and makes them on steroids, so to speak. Each provider agency needs to have an established infectious control officer. Fire-based agencies have various regulations through NFPA to follow that talk about workmen's environmental issues and infectious disease control. So So the bottom line is to reduce the risk for infectious disease exposure for all pre-hospital providers. You'll protect your patients, yourself and your colleagues, and most importantly, at least in my mind, is my family, because I don't want to bring this stuff home. Many times pre-hospital providers will be exposed and not be aware of the exposure. And seemingly healthy persons can be harboring potential infections, as we mentioned already. Hospital providers routinely carry, again, MRSA in their nasal cavities. Exposure risk reduction. All pre-hospital providers need to exercise standard precautions. It used to be universal precautions, it's now called standard. And I think this needs to be for every patient encounter. When I lecture and I ask random polls, how many people routinely use gloves? Most hands go up. How many people use goggles? Yeah, not so many. And when I talk about masks, whether it's a simple surgical mask or N95 particulate respirator, no hands ever go up. I do a lot of wound care now, and I wash my hands before I touch the patient as soon as I walk into the exam room, and immediately following patient contact. And I wear gloves during the majority of my visit. Again, waterless hand sanitizers are an option if soap and water are not immediately available. I'll say this multiple times during this presentation. Again, when soap and water becomes available, it is incumbent upon you to properly wash your hands, use adequate technique, adequate time, and make sure you cover all surfaces. Again, standard precautions protect you, the EMS provider, from pathogens spread by various routes of transmission. These routes include direct contact, so droplet, which can hang in the air, can go outwards of 3 to 6 feet. These are the larger particulate matter, say after a good sneeze. Airborne particulates, which can happen after a cough or just regular respiration. Things like tuberculosis, meningococcal disease. These agents float literally on air currents, somewhere between sometimes up to 3 to 6 hours in the room, and upwards of 10 to 20 feet away. There's aerosolized, so even though the disease agent may not necessarily be infectious, from an airborne standpoint, when you suction somebody out, you aerosolize all sorts of lovely secretions that then go flying through the air, contact your skin. Say it lands on your forehead. On me, I have a larger surface area because I'm a little follicularly challenged, and so the next time you touch your face, you spread it from your face to your mucous membranes in your mouth, your nose, rub your eye. And again, there's the classic bloodborne transmission that people classically think with hepatitis B, hepatitis C, and HIV infection. Appropriate PPE for each, and let me say, for each and every patient contact consists of 1, nitrile gloves, eye protection, and if there is a risk, you need to think about an N95 mask. Many EMS authorities recommend N95 masks, the particulate respirators as they're called, for every EMS encounter, except all those that they are, quote, certain don't have any infectious diseases, like the trauma patient. However, you don't know what underlying disease factors these patients may or may not have. Again, after every inpatient encounter, you need to wash your hands. EMS providers are among the worst for following this guideline, and it's one of the easiest and best ways to reduce spread of infectious diseases. Again, the life you save might be your own. So let's go over contact transmission. Through direct contact with pathogens on the patient's skin or surface, quote, fomite that the patient has touched, or their fluids containing the pathogens have hit. So somebody throws up and you don't know that that was just merely wiped up in their home, and you put your hand down, that's direct contact. So emesis, vomit, feces, and or urine draining wounds, secretions such as saliva, semen, and or breast milk. And although I certainly hope that EMS providers are not coming in contact with semen and or breast milk, that really became a huge issue for Ebola virus, because it clearly was transmitted sexually and from mother to child. And furthermore, they found that in some Ebola virus patients, there are certain immune areas of the body that are kind of sequestered, somewhat like the vitreous tumor of the eye. Excuse me. And they have actually found Ebola, once the patient's titers have gone down and they've survived, can remain an active area for Ebola to thrive. Again, providers need to change their gloves, because gloves can easily transmit pathogens to other surfaces. The classic is the steering wheel of the ambulance, stethoscopes that we talked about, blood pressure devices, and your street clothes. When I was working in the emergency department, I routinely changed in my garage. I took off, whether I was wearing scrubs or not, in the garage. I took off my sneakers and anything else that came home with me from the emergency department, because I did not want to track it in to my home and expose my family. Droplet, we've talked about that already, but basically it's through the inhalation or the absorption of bodily fluids and or substances into your eyes, your mucous membranes. Examples are various respiratory viruses such as influenza A and or B, adenovirus, which are many times the common cold, and rhinoviruses, pertussis, also known as whooping cough, and strep throat or streptococcal pneumoniae are easily transmitted via the droplet transmission. Here we have a, quote, innocent sneeze. Looking at this slide, you should be grossed out. This is a high-speed flash, and it shows that if you're standing 3 to 4 feet away, you've just been hit with a barrage of infectious agents. And the smaller particulate matter, as already discussed, become airborne, and they hang. They have a fair amount of hang time. And airborne transmission. Classic is tuberculosis, and we're really talking about particle sizes in the micron size, and they just float through the air. Measles is that way. People, and chickenpox, and people say, "Oh, big deal, chickenpox." Well, if you think about it long term, shingles is not a pleasant disease, and if you happen to get shingles in your face, there's a high percentage that will affect your eye. You can get permanent corneal scarring and therefore decreased visual acuity. As I said, these can hang suspended for prolonged periods of time. They can travel relatively large distances, and many of these illnesses have very long-term health consequences for the provider, let alone the patient. We always need to be vigilant about the next emerging infectious disease. West Africa demonstrated how Ebola virus disease, as it's now called, not the hemorrhagic fevers, can hit anyone. Public health is very concerned about people who volunteer in these hotspots and would come back and be, quote, a monitored traveler. And they'd be monitored by public health departments for at least 21 days, which is 2 incubation cycles. The incubation cycle for Ebola, the maximum is 21 days, the minimum is 2. Now, the new hot topic is Zika virus, and many people are discussing should they cancel the Olympics, and I know many athletes are not choosing to attend. because Zika is also now thought to be sexually transmitted. So again, care needs to be exercised for each patient encounter. This needs to be continued past the patient transfer portion and it's complete. We'll talk more about that. Placement of a mask on a patient. You really need to be very careful before you randomly put a mask on a patient who may be wheezing, coughing, sneezing because of their clinical condition. If they have underlying pulmonary disease, such as chronic obstructive pulmonary disease, also known as emphysema, asthma, they have clinically a pneumonia, their work of breathing is already increased. Their respiratory status is tenuous, and you can cause them to go into respiratory failure and subsequently cardiac arrest. It's considered bad form to knock your patient off by trying to help them or protect yourself. Managing a patient's airway, whether this is a basic life support or a primary airway or an advanced airway such as King airway, LMA placement, intubation, you need to always exercise caution because again, with diseases like meningococcal, which are airborne, you can get exposed while putting one of these airways in and have to go on prophylaxis to increase the chances that you don't come down with this disease yourself. I've been on prophylaxis more times than I care to think about in my career. Again, use extreme caution when suctioning the patient's airway since droplets and airborne particles will be generated, not if, but will be. Removing PPE. It's a lot more difficult than you might think. Doffing or removing the PPE can be fraught with hazard. Physicians get trained when we do our surgical rotations on how to appropriately remove the surgical garb. Many times, EMS providers are not taught until after paramedic school. You need to exercise extreme caution not to contaminate yourself or others during this process. This was really stressed during the height of the Ebola virus disease processes. It's extremely easy to contaminate yourself and infect your own eyes, mucous membranes, and skin if you don't exercise caution. Again, I sound like a broken record, but always change your gloves before re-entering your vehicle's cab. I always wore 2 pairs of gloves. One that I would take care of patients, 2 that I would take off as an extra layer of precaution. Not a bad practice. High-risk diseases. Many have more than a single mode or method of transmission. Methicillin-resistant Staph aureus, many respiratory viruses, and meningococcal disease. And again, if you get exposed to some of these, in particular meningococcal disease, you require prophylaxis. Now, there is a vaccine for certain strains of meningococcal disease, but not all of them. Let's talk a little bit about infectious diseases, how they present in similar fashion. You know, everybody says, oh, well, I've got the flu when you go and ask them. Well, an influenza-like illness, which really became defined or much more aware of during the H1N1 crisis. What's a fever? Well, for an influenza-like illness, it's really 100 degrees. Not much. Do they have an acute onset of cough and or sore throat? Many times patients with an ILI or influenza-like disease can also present with other symptoms because it's not necessarily influenza but an influenza-like disease. So do they have shivers and chills? Do they have malaise? How you feel after a 24-hour shift? Do they have nausea, vomiting, and diarrhea? This is not necessarily influenza, but it's a generic viral approach. Remember that diseases like Ebola virus disease, hemorrhagic fevers, all present in a similar fashion with a relatively, quote, minor onset before they get seriously ill. Let's talk a little bit more about environmental disinfection. I quoted the literature at the beginning of this, and the bottom line is studies demonstrate that there's a consistent lack of the disinfection process for ambulances, and I can't stress enough that our equipment, our durable equipment, is, for lack of a better term, a breeding ground unless we properly maintain it. Again, when respondents were indicated that their ambulance was routinely cleaned, and they still were able to grow MRSA from, quote, clean, dry surfaces. And again, the stethoscope studies are classic. They've done that with nurses, with physicians, with paramedics, because people forget about the stethoscope. Or another one that nobody really thinks about either is the pen light when you're looking at somebody's pupillary response. Receiving facilities. It's considered good form to let the receiving facility know that your patient is experiencing respiratory symptomatology, so they may want to try to place this patient in an isolated area. If they have a negative pressure room, which many emergency departments do, they may want to put the patient there because that area is directly vented outside of the healthcare facility. In summary, the best way that I can think about it is the hazmat approach to infectious diseases. Remember, any hazmat expert, hazmateer, would not approach an unknown substances release if they don't know what the material is without the proper PPE being donned or put on. It's just inconceivable to them. Well, you should treat every patient encounter that potentially has an infectious disease in a similar manner. Your armament, your PPE, are nitrile gloves, eye protection, and an N95 particulate respirator for the infectious disease patient. This is the baseline. As been shown with hemorrhagic fevers, EVD, Ebola virus diseases, that you may need to go above and beyond. Remember, the life you save may be your loved ones. Thank you for your attention. Have a great day.